Examination of the knees. A crucial assessment. Hello there, Margaret. I say, are you asking the gods to bless your next Oski performance? I see. Well, remember not to overdo the kneeling, or soon your physician may be forced to perform examination of the knees, a crucial assessment. After washing your hands and gaining consent, adequately expose your patient, Margaret. Inspection. After asking the patient to walk so you can assess their gait, observe both knees from all angles. Check for scars, swelling, wasting, and deformities. Recall that in varus deformities, the distal limb is pointed medially, and in valgus deformities, the distal limb is pointed laterally. For extra marks, ensure that you state that normal alignment can be 5 to 7 degrees valgus. Palpation. Observe the patient as they lie down and inquire about any pain. Offer to compare the circumference of the thighs to check for quadriceps wasting. Proceed to compare the temperature of the joints. Superb work, Margaret. Now, perform the classic tests for knee effusions. For the patella tap, attempt to milk any fluid down from the suprapatellar pouch, then push the patella down. If you sense a tap, you may well have detected a knee effusion, Margaret. For the bulge test, empty the medial compartment of any fluid before sweeping your hand over to the lateral side of the knee. A visible bulge in the medial dimple is a sign of a smaller knee effusion. Terrific, Margaret. Now, flex each knee to 90 degrees to continue palpation. Be sure to demonstrate a methodical approach, Margaret. Perhaps begin at the tibial tuberosity and move proximally. Tenderness of the tuberosity in a young male may indicate Osgood-Schlatter's disease. Tenderness of the patella tendon suggests tendinitis, and pain when the patella is palpated may be a sign of pre-patellar bursitis. Make sure you feel the joint lines and both the medial and lateral collateral ligaments. Never forget to feel in the popliteal fossa for a Baker's cyst, Margaret. Complete palpation by warning the patient you are going to press into the posterior aspect of their knee and proceed to assess the popliteal pulses. Movement. Both active and passive movements should now be tested. Ask the patient to pull their heels to their buttocks. Be sure to feel for crepitus as you test each knee, Margaret. Clear crepitus can be a sign of osteoarthritis or chondromalacia patella. Then test for undesirable extension by lifting the patient's straight legs right off the couch. Recall that normal range of movement at the knee is 0 to 140 degrees. Marvelous movement, Margaret. Now comes the time for special tests of the complex knee ligaments. Begin by simply assessing for posterior sag. A positive sag sign suggests posterior cruciate ligament damage. Never forget this part of the examination, Margaret, as missing a posterior sag can lead to a false positive anterior draw test. Speaking of which, let's move on to test the anterior cruciate ligament. Ask the patient if you could perch on their feet for a moment or two and grasp the flexed knee with your thumbs over the tibial tuberosity, checking hamstrings are relaxed. Proceed to pull the tibia towards your body, Margaret. If movement is greater than 1.5 centimeters, the test is positive. A false positive may be caused by a medial meniscectomy or a posterior cruciate ligament deficiency. You may now offer to perform the posterior draw test and Lachman's test, but beware, these will not add to your exam if you have already assessed for posterior sag and performed the anterior draw test. Performing them simply eats away at your remaining time, Margaret. Excellent! Grasp the limb thus to test the two collateral ligaments. This can be done both with the leg in full extension as well as with 30 degrees knee flexion. Instability in full extension is not present in isolated ligament ruptures, and thus indicates a more severe injury. As always, do not force movements if the patient appears to be in pain, Margaret. You can now state that you could perform the apprehension test to assess for a current patellar dislocation and McMurray's test to detect meniscal tears. It is worth remembering that McMurray's test is rather unreliable, and joint line tenderness is a much more important finding when there's meniscal damage. To perform McMurray's test, flex the knee to 90 degrees, hold the appendage in external rotation, and place your fingers at the medial aspect of the joint line. Now, flex the knee, attempting to impinge the posterior horn of the meniscus against the medial femoral condyle, and always be sure to apply a varus stress as you extend the leg, Margaret. After thanking your patient and making them comfortable, offer to perform neurovascular assessments of the lower limb and to examine the joints above and below the knee. Then present your findings concisely, Margaret. For instance, one could say that Mr. Smith is comfortable at rest, with no visual signs of knee pathology. There is a degree of joint line tenderness on palpation of the left knee. Range of movement is 0 to 140 degrees in the right knee, but limited by pain to 0 to 100 degrees in the left knee. Posterior sag is not present, and the anterior draw test is positive in the left knee. This suggests damage to the left anterior cruciate ligament. Superb work, Margaret. You certainly shan't be bent out of shape next time you have to demonstrate the art of examination of the knees, a crucial assessment.